Well, we'll have been in a situation where we know a patient who had low blood pressure with prior dialysis. This is often encountered as a nephrologist. For my QI project, I decided to pick a topic that was bothersome every time I encounter it, yet clinically relevant. At one point during my first year of fellowship, I asked myself, what can be done to prevent low blood pressure during dialysis? And this is after acute concerns are ruled out. Hence my QI project, the impact of dialysate sodium concentration on intradialytic hypotension. We'll talk about why is prevention of intradialytic hypotension important, why the sodium bath matters in intradialytic blood pressure, is interdialytic weight gain a concern? We'll talk about my quality improvement project and conclusions in further studies. First, why is prevention of intradialytic hypotension important? With a frequency of 20% to 10%, plus minus 10%, patients with intradialytic hypotension are at higher risk for all-cause mortality, cardiovascular disease, myocardial infarction, cardiovascular mortality, increased volume overload, decreased quality of life, not to say hospitalizations. And I think we all got the message that intradialytic hypertension is detrimental for the patient. In this study from 2015, we can see a trend of increased all-cause mortality with increased percentage of dialysis sessions with intradialytic hypotension. Same in this study from 2018, we can see a 5% drop in proportion of intradialytic events. Like we can see even a 5% drop in proportion of intradialytic events. Let's say, for example, if we focus on figure C, if we go from 41% to 36% and approximate 30 percentage points reduction can be achieved in regards of mortality risk. Let's talk more about dialysate sodium concentration and why it matters for intradialytic hypotension. In the beginning of dialysis, Dr. Kolff, who was the first person attributed to successfully dialyze the patient, believed a sodium bath of 126.5 will help control hypertension and thirst. This was in the 1940s. It is likely that for Scribner's dialysis prescription, the dialysate sodium concentration was around 130. However, I couldn't find data stating the exact concentration used. Another thought of using a lower sodium bath, specifically lower than serum, is to overcome something called the Gibbs-Donen effect. And that's when sodium it gets trapped by negatively charged proteins that don't get filtered at the blood membrane interface. So why sodium bath is so important? A lower sodium bath has been associated with increased risk of intradialytic hypotension. Higher sodium bath has been associated with increased higher blood pressure. A lower sodium bath plus intradialytic hypotension is associated with increased volume overload and decreased quality of life. And the trend of using a lower sodium dialysate was based on expert opinion from 2014. In 2014, 4 recommendations were made by experts. Unfortunately, due to lack of clinical trials, and these were normalization of extracellular fluid volume, gradual fluid removal, avoiding intradialytic sodium loading, avoiding sodium modeling, using sodium bath between 134 to 138, and avoiding dietary sodium. Recently, just in 2023, a large Fresenius study with more than 2 million patients found that dialysate sodium of 138 or less to be associated with almost like a 50% increase in mortality. This is another study from 2024 showing increased ambulatory blood pressure monitoring with higher sodium bath in a 72-hour period. There's also been argument about the effect of sodium bath and left ventricular mass. There's concern for fluid overload in dialysis patients contributing to cardiovascular morbidity and mortality, hence a trend to use a lower sodium dialysate trying to reduce fluid overload. In the largest randomized clinical trial to date in regards of left ventricular mass, essentially no difference was found between sodium bath and left ventricular mass. In regards of interdialytic weight gain, studies have shown interdialytic weight gain trend of 0.1 to 0.3 kilograms with higher sodium bath, and then higher interdialytic weight gain have been associated with worsened outcomes. But let us switch gears and dive into the quality improvement project itself. Knowing all this, I decided to pursue my quality improvement project based on sodium bath concentration and effect on intradialytic hypotension. We were able to follow 28 patients for 6 months at Scribner NKC. They had at least 1 month of baseline data where patients had at least one systolic blood pressure measure less than 90 while on dialysis. Not all patients made this criteria. I think 4 of them did not have low blood pressure before change. We changed the sodium bath from 135 to 138 after the primary nephrologist agreed. And then we collected the data from like 3 months before changing the bath and then 3 months after changing the bath. And this was from December 2024 to May 2025. And we only look at patients that we changed the sodium bath from 135 to 138. All the staff was aware of the ongoing quality improvement, and even our unit manager, Cindy Madrid, made this bulletin at the dialysis center. For analysis, Leila was kind enough to help us at last minute for a better interpretation of the data. From the 28 patients, we were able to gather 2,023 events over 6 months. And analysis was done using a linear mixed model with random intercept for participant. Results were as follows. It is a busy slide, but I'll break it down per session. First, we have the categorical variables. Those are the first 2 on the y-axis. For the categorical, we have in the intradialytic hypotension, and then starting systolic blood pressure greater than 165. And then for columns, we have a pre-bath change. That's the first column. Post-bath change, the second column, and then its difference. So let's start with the categorical. For intradialytic hypotension, before the bath was changed, the proportion of events was 17.5%. And after sodium bath change, it was 12.8. And that's a 4.7% difference. For starting systolic blood pressure above 165, before bath exchange, the proportion of events was 16.5%, and after sodium bath exchange, it was 18.6%, a 2.1% difference. This data shows that changing sodium bath from 135 to 138 indeed seems to decrease intradialytic events without experiencing marked increase in blood pressure. For continuous variables, we'll look at absolute starting and low systolic blood pressure numbers. We have weight from last treatment, weight pre-dialysis, weight in between dialysis, and weight removed during dialysis. From the table, we can see there was a mathematical significance, but clinically insignificant increase in starting systolic blood pressure. We can also notice that low systolic blood pressure increased about 5 points. And there was no difference in weight before dialysis, weight in between dialysis, or weight removed with dialysis. Those will be like the bottom three rows essentially. I created this figure for more of a visual learners, but essentially has the same information regarding the starting systolic blood pressure and the low systolic blood pressure and the weight itself. Now in my presentation, I'll shortly talk about the conclusion and further studies. Increasing sodium dialysate concentration from 135 to 138 seems to decrease intradialytic events about 5%, with minimal increase in pre-dialysis blood pressure and without increase in interdialytic weight gain. In regards of further studies, we will discuss with Matt Rovira to replicate in different NKC sites. There's also an ongoing trial called Resolve, which is evaluating 135 versus 140 sodium bath. However, mainly looking at cardiovascular events and death. I would like to thank Dr. Brendan Shannon, the NKC Scribner staff, and kudos to Cindy Madrid for doing that bulletin, to Dr. Leila Selnick, Dr. Matt Rovira, and Dr. Yoshio Hall for helping make this quality improvement project possible. And I'll take questions now.
Thank you, Manny, for that. Thank you, Manny, for that great talk. We have this nifty microphone here we're going to pass around.
Manny, that was amazing. You actually did an interventional study in the course of your fellowship, so congratulations for that. I just wanted to make 2 points. You know, there's a lot of focus on dialysate sodium as a practice approach for the entire unit. There's a concept that there's a need to individualize dialysate sodium because there are people have a certain set point for sodium for themselves and they drink water or restrict themselves to that level. And so if you have a concordant dialysate sodium rather than a discordant, your events and also your sense of feeling washed out after dialysis likely is better. The big challenge in all of it is the way we measure dialysate sodium in a dialysis system is by measuring conductivity, which is very imprecise. It is plus or minus 1 milliequivalent, so it could be like plus or minus 1 or 2 milliequivalents. So the range in what you think it is and what it actually is could vary quite a bit. And that's an issue, neither here nor there, but just important to acknowledge that.
No, that's great. Thank you.
I think I just wanted to use them.
What I'll mention, I think in the Fresenius study itself, they also saw like less. I think they kind of like break it down after, but less than 135 itself, because they compare the serum sodium as well, but they tend to saw a trend to more intradialytic hypotension with lower sodium, like serum sodium as well. But that's good to keep in mind um, as well. We're trying to look at the difference itself, like the gradient. Most of the time, you know, when I did it before all this, it was about 1.5 when pulling all the data. But I agree, it's always good to keep in mind, as you mentioned, that the bath itself is measured through conductivity.
Thanks, Manny. I don't echo as much as you did. So I just, can you hear me?
Yeah, Sarah?
Yeah.
Yes.
Good job. So no, super cool project. I think the nice thing about what you did is you can actually get some like really granular level data as opposed to these big, huge, you know, studies where they're using thousands of patients. But I was just going to ask, did the patients notice any difference? I know Yoshio, is he here? No, Yoshio always tells us that he used to change the sodium baths and the patients would get mad at him because they would be really thirsty. But I was just wondering if the patients had any thoughts about the change.
For the patients itself, unfortunately, we did not gather data, you know, in terms of like symptoms or anything like that. We were mainly just, you know, was mainly like just looking at the chart itself. But no, I did not gather data in terms of symptoms or anything like that.
Maybe I'll ask a different way. Did anyone drop out and say, no thanks, I don't want to be part of this anymore?
Physicians, yes.
The physicians dropped out.
Yeah, so you know, we
Right.
didn't ask that, you know, because we were not planning on publishing, so we did not, you know, did more of an, you know, IBM or anything like that. So we mainly just talked with physicians, and some physicians were not on board for it.
Sorry, Manny, you can't hear this. Brendan just said nobody dropped out. Some of the physicians just didn't respond to you.
Exactly, yeah. Sorry.
Yeah. I will say I'm having that problem too. So I'm going to be sending out more emails to all of you very shortly. I really want to throw this. Okay. Okay, you ready?
This is too funny.
Can you hear me?
Yes, I can hear you.
I was just a little bit confused about the participant selection. I'm sorry if I missed it. So the individuals that were included were people who did have hypotension in a 6-month period, or how did
No,
you?
that's good. That's a good, yeah. You know, when we started, that was ideally what we were like looking for. However, there were some patients who did not had hypotension after when, you know, when we gather it. And so, but the sodium bath, what's changed itself from 135 to 138, and we mainly decided to include them mostly for the safety as well. You know, if we see more of the weight increase and things like that, and the blood pressure part, so it's more of a safety concern that we decided to keep them. We did not include any patients who remain, like for example, in 135 of bath, or if they were already in 138, or any other type of bath of sodium level itself. So we only, you know, look at people who change from 135 to 138. But yes, there were about like 4 patients who did not have low blood pressure before the bath itself was changed.
And then as a follow-up, so how long was your study period? How long were they on the higher sodium bath? And you said
Yeah,
March 13th.
no, that was good. So it was 3 months.
Thank you.
Yeah,
Very nice
so
work. That's really
we
great.
collected data like 3 months before we change it. Like before March, it was December, January, and February. So anywhere who had, you know, a dialysis session at that point, and then remain with us, and it was on a 135 bath, we changed them to like a 138, and then we did that for 3 months.
Manny, hi, it's Leah. That was a beautiful presentation of a really challenging, fast-paced study and a subject near and dear to my heart. When I was a fellow in the 1990s, everyone was on 140 and nobody ever even talked about going lower. So one thing I'm wondering is in the hospital, do you recommend that we routinely use baths that are higher than 135, or that we look at the patient's sodium and individualize it? What would be
No,
your recommendation for hospitalized patients?
no, that's great. So, you know, I do believe on a personalized a sodium bath, as Rash was saying. For example, for patients who, you know, let's say they don't drop their blood pressure, and their blood pressure it's in the 170s or so. I don't think like increasing their bath itself will be useful. So I tend, you know, I tend to lower the sodium bath itself to help with blood pressure too. But just for patients who are experiencing hypotension, you know, after adjusting, let's say, blood pressure medication or ultrafiltration rate, and they still dropping, I do think increasing their sodium, or at least a 138 sodium, should be useful. I tend to manage or like prescribe based on blood pressure, like the sodium bath itself based on blood pressure. If their blood pressure is about in the 120s, 130s, I tend to do more of the 138 in that sense, to help prevent dropping their blood pressure and try to pull more fluid as I'm able to.
Great, thank you.
What other questions?
All right, well, thank you so much, man. It looks like that's all of our questions. And so with that, thank you. And I want to thank all of our graduating fellows for all of their hard work, and not just with, of course, their scholarly projects, but with everything that's gone into it. And so, and I want a special plug for next week's graduation on Wednesday. Hope all of you can attend. And yeah, this is the last nephrology grand rounds of the academic year. So we'll see all of you back again in September. So.
Thank you.